Good evening, everyone, and welcome to all. Myself, Rupsha from Clearnet, the designated session assistant for a seamless experience of the session. Clearnet is very proud to be a digital partner of this event organized by Indian Medical Association, Thiruvananthapuram branch. And the topic of today's session is practice changing update in cardiology. Clearnet is India's most trusted and widely used digitech platform with multiple enriching services exclusively for doctors only. So let's begin today's session, for which I would like to invite Dr. G.S. Vijay Krishnan sir. Sir is the president of AMS. Sir, over to you. Kindly proceed with your talk.
Thank you, Ms. Ruba. Respected convener of AMS, Dr. Anand, and respected seniors and dear friends. നമുക്കറിയാം കഴിഞ്ഞ മാർച്ച് 10 തൊട്ട് കുറേ ആക്ടിവിറ്റീസ് കൈമറ്റുവാണ്ടം മാറ്റിവെച്ചിരിക്കുകയായിരുന്നു. നമ്മുടെ ഒരു അൺഫോർച്ചുനേറ്റ് ഇൻസിഡൻറ്റ് നമുക്കുണ്ടായിട്ടുണ്ട്. നമ്മുടെ ഒരു സഹപ്രവർത്തക, നമ്മുടെ മകൾ തുല്യമായ ഒരു കുട്ടിയെ നമുക്ക് നഷ്ടപ്പെട്ടു. എങ്കിൽ പോലും നമ്മുടെ ആക്ടിവിറ്റീസുടെ മുമ്പോട്ട് കൊണ്ട് സാഹചര്യമുണ്ട്. നമ്മുടെ ആശുപത്രി അതിക്രമമായിട്ട് ബന്ധപ്പെട്ട വിഷയങ്ങളിൽ ശക്തമായൊരു ഓർഡിനൻസ് ഗവൺമെൻറ് ഇപ്പം പുറപ്പെടുവിച്ചിട്ടുണ്ട്. നമുക്ക് സ്വസ്ഥമായി സുരക്ഷിതമായി പ്രാക്ടീസ് ചെയ്യാൻ പറ്റുന്ന രീതിയിൽ ഒരു ഓർഡിനൻസ് ആണ് ഇപ്പം വന്നിരിക്കുന്നത്. നമ്മുടെ സംസ്ഥാന പ്രസിഡന്റ് ഡോക്ടർ സുൽഫി, നമ്മുടെ ബ്രാഞ്ചിന്റെ അഭിമാനായ ഡോക്ടർ സുൽഫി എൻ്റെ ടീം നമുക്ക് വേണ്ടി ഒരു ഓർഡിനൻസ് കൊണ്ടുവരുന്ന സാഹചര്യം കൂടി ഇപ്പം നിലനിൽക്കുന്നുണ്ട്. ആ സാഹചര്യത്തിൽ കൈമറ്റുവാണ്ടം വീണ്ടും ശക്തമായ രീതിയിൽ നമ്മുടെ ആക്ടിവിറ്റീസായിട്ട് മുമ്പോട്ട് പോവുകയാണ്. നമ്മുടെ AMSന്റെ ആക്ടിവിറ്റീസ് ആയിട്ടുള്ള നമ്മുടെ കണ്ടിന്യൂ മെഡിക്കൽ എഡ്യൂക്കേഷൻ്റെ പാർട്ടായിട്ട് ഇന്ന് നമുക്കൊരു പ്രാക്ടീസ് ചേഞ്ചിങ് അപ്ഡേറ്റ് എന്ന രീതിയിൽ അപ്ഡേറ്റ്സ് ഇൻ കാർഡിയോളജിയാണ് ഡോക്ടർ ആനന്ദ് നമുക്ക് വേണ്ടി കാഴ്ചവെക്കുന്നത്. എല്ലാവിധ ഭാവങ്ങളും നേരുകയാണ്. ഞാൻ കൂടുതൽ ദീർഘിപ്പിക്കുന്നില്ല. എല്ലാവിധ ആശംസകൾ നേർന്നുകൊണ്ട് നിർത്തുന്നു. താങ്ക് യു.
Thank you. Thank you, Vijay sir. Rupa, is my audio and video okay?
Yes, sir.
Okay. Thank you. Thank you, Vijay sir, for that kind introduction. So I'll be talking about practice-changing updates in cardiology. As you know, the last several years, there have been a fair bit of new advances in the field, which each of us should ideally integrate into our day-to-day practice to improve the outcome of our cardiac patients. I'll touch upon a handful of these updates under these headings of hyperlipidemia, diabetes and heart disease, heart failure, diagnosis and treatment of coronary disease, arrhythmia management, sudden cardiac death, as well as valvular heart disease. So let's start with hypercholesterolemia, which we all know is a cornerstone of treatment for atherosclerotic cardiovascular disease and coronary disease, which amounts to the vast majority of the cardiac conditions that we deal with. And as we all know, year by year, there's a lot of data coming in and the guidelines keep changing. And the goal LDL is what I want to stress about. The most recent trials have pinned down the target goal for patients for secondary prevention. Secondary prevention as in patients who have already been diagnosed with coronary artery disease or have previously had a myocardial infarction. In such patients, the LDL goal is targeted at less than 70. And patients with high risk, it is less than 55, and very high risk, which is patients having acute coronary syndrome, multiple ones in the last 2 years, the LDL goal is less than 40. So those are very kind of stringent targets. Previously, it used to be less than 100, which is what it is for primary prevention. Patients with moderate risk, it is less than 100, and low risk patients, it is less than 116. So how do we get these patients to target? Statins continue to be the cornerstone in terms of controlling your cholesterol levels, moderate to high dose statins. We have come across various other cholesterol lowering drugs such as cholestyramine and niacin and so on and so forth, which really have not stood the test of time. So it's still statins which are able to reduce our LDL to goal to this date. If the LDL is not at goal despite on moderate to high risk statin, then ezetimibe, which prevents cholesterol absorption in the small intestine, is the second agent which can be added. And there is a fair bit of data showing that combination of statin and ezetimibe is recommended in patients with high LDL. Then came a PCSK9 inhibitor, which is actually a monoclonal antibody, which targets certain receptors in the liver thereby increasing the LDL receptors on the liver surface, thereby sucking out a lot of LDL out from the blood, which is able to reduce the blood level of LDL to almost as low as 20. And there are trials showing better clinical benefit with lowering LDL to that degree. Bempedoic acid is a newer drug which kind of acts along the lines of statin. It is an ATPase citrase lyase inhibitor. So combined with statin has been shown to reduce LDL. So these are the main drugs which are currently under the in the guidelines: statins, followed by ezetimibe, PCSK9 inhibitors, and bempedoic acid. I just wanted to touch upon what is high intensity and moderate intensity statin. High intensity is atorvastatin 40 to 80 and rosuva 20 to 40. And moderate is atorva 10 to 20 and rosuvastatin 5 to 10. Quick word on PCSK9 inhibitors, which is kind of the wonder drug as far as LDL reduction is concerned. This is actually an injection, which is also being released in an oral formulation. It is usually reserved for patients with familial hypercholesterolemia with high LDL despite being on statin and combination with ezetimibe, and also in secondary prevention in very high risk patients, having recurrent acute coronary syndrome whose LDL level is more than 70 despite being on a combination of statin and ezetimibe can benefit from PCSK9 inhibitors. Moving on, diabetes and heart disease. We know that over the last several decades, we have had so many different newer insulins, newer oral hypoglycemic drugs, which are able to reduce your sugars and HbA1c, but have not succeeded at reducing the mortality in these patients, which is mostly attributable to cardiovascular mortality. In the last 10 years, we have had newer molecules, predominantly these two which I have listed, SGLT2 inhibitors and GLP-1 analogs. These are two specific diabetic drugs which have been strongly shown to reduce cardiovascular mortality in diabetic patients beyond glucose reduction and HbA1c reduction. How do these act? GLP-1 receptor agonists, they have a direct anti-atherosclerotic role beyond reduction in glucose level, thereby has an overall protective milieu in terms of CV mortality reduction. SGLT2 inhibitors actually acts on the kidneys, but beyond glucose reduction has hemodynamic as well as cardiometabolic milieu changes, which favorably causes weight reduction, blood pressure reduction, and heart failure reduction. And these two are currently considered as must be added drugs in diabetic patients in order to improve their long-term cardiovascular mortality. You're probably familiar with these drugs: empagliflozin, dapagliflozin, and canagliflozin. And GLP-1 analogs are injectable formulations initially, dulaglutide, lira, and lixisenatide, followed by a newer oral formulation called as semaglutide. These are the various trials of EMPA, CANA, and DAPA, which have shown that there is a cardiovascular mortality reduction in diabetic patients. So I'll mostly be touching upon and mentioning most of these advances. We will go into the details during the discussion if you have any specific questions. Let's talk about heart failure. Heart failure, traditionally, we refer to heart failure as systolic heart failure patients with reduced ejection fraction, either from ischemic cardiomyopathy or non-ischemic cardiomyopathy, which are idiopathic myocarditis or valvular heart disease and so on. But now there is a broader definition of heart failure. It is not only reduced EF, but a heart failure with preserved EF is an entity which is better recognized now. This is attributable to diastolic dysfunction, wherein the left ventricle becomes stiff. It is not able to relax well. So even if it is able to pump well, it is not able to receive blood and pump overall effectively. Predominantly seen in patients with hypertensive heart disease, hypertrophic cardiomyopathy, left ventricular hypertrophy from aortic stenosis, restrictive cardiomyopathy, and so on. So even further, heart failure is currently divided into three broad categories. One with systolic dysfunction is called as heart failure with reduced ejection fraction with EF less than 40%, preserved ejection fraction with EF more than 50%, and mid-range ejection fraction between 40 and 50%. This is a kind of classification depending on the ejection fraction on echocardiography. So what is new as far as heart failure treatment is concerned? Heart failure treatment has been revolutionized with a lot of molecules which has been added over the last several decades. The older ones which we are familiar with, beta blockers, which blocks this sympathetic axis. The renin-angiotensin aldosterone axis is inhibited by AC inhibitors, ARBs, and mineralocorticoid inhibitors. And the newer drugs over the last decade is neprilysin inhibitor, also referred to as ARNI, or a combination of angiotensin receptor blockade and neprilysin inhibitor. We are all familiar with natriuretic peptides, BNPs and NT-proBNPs, which are markers that we check in the blood for diagnosing heart failure. And these molecules have actually been shown to have a cardioprotective effect in terms of vasodilatation, diuresis, prevention of hypertrophy and fibrosis, and so on. So neprilysin inhibitor within ARNI is the newer drug that we can offer to our patients with heart failure. Again, SGLT2, but which we just talked about, although primarily a diabetic drug, has been found to have very strong heart failure prevention. In all kinds of heart failure. We talked about 3 different kinds of heart failure: reduced, preserved, and mid-range EF. All different category of heart failure patients have been seen to benefit from SGLT2 inhibitors. So these are what has been termed as the different pillars of heart failure, and each of us should make sure that our heart failure patients, but I'm referring to heart failure with reduced ejection fraction, should be on each of these pillars: beta blockers, mineralocorticoid inhibitors, AC inhibitors, ARBs, neprilysin inhibitor, ARNI, and SGLT2 inhibitors. So why so? Because these are the pillars which have been shown to have mortality benefit in the long term in terms of causing left ventricular reverse remodeling, improvement in ejection fraction, improvement in the LV size, and longevity. Diuretics and digoxin that we are all familiar with only causes symptomatic benefit. They might reduce hospitalization, but may not help the patient live longer. There are specialized device therapies, which we will talk about a little later. I'll just mention it here. One is internal cardioverter defibrillator for prevention of sudden cardiac death in heart failure patients, and cardiac resynchronization therapy for improvement of left ventricular ejection fraction in patients with heart failure. So a brief note on heart failure with preserved ejection fraction, which we talked about. On the echo, the EF is normal or more than 50, which kind of tends to fool a lot of us because the heart pumping is normal. But what we don't realize is the fact that if you closely look at the report, they also mention about diastolic function. And if the diastolic function is abnormal, usually in the setting of left ventricular hypertrophy, that is when a patient has heart failure with preserved ejection fraction. And we have found that it is a very heterogeneous group of patients with comorbidities such as hypertension, diabetes, CKD, and obesity, which causes hypertrophy and stiffness of the ventricle, leading to clinical heart failure. And interestingly, all these pillars that we talked about are not very effective in these group of patients. It is predominantly effective in heart failure with reduced EF, except for SGLT2 inhibitors, which have been shown to be effective in heart failure with preserved EF also. So we come back to SGLT2s again, because specifically in diabetic and non-diabetic patients with low to high atherosclerotic risk factors with reduced EF and preserved EF, SGLT2 inhibitors have been shown to be beneficial in terms of combination of CV death reduction and heart failure hospitalization. You're seeing a ECG with ST elevation MI. Treatment for STEMI has improved over the decades. There is a great focus on reduction of the total ischemic time by reducing the door to balloon time. There is better awareness amongst the people in terms of going to a hospital, getting an ECG. And if they are in a peripheral center, thrombolysis should be offered. And if they are in a facility with cath lab, primary angioplasty should be offered. A peripheral center from where the patient can be shifted to a cath lab facility within 90 minutes or so, they should preferably be transferred to undergo a primary angioplasty, because time equals muscle. And earlier we open up the infarct-related artery, more of myocardial salvage that we can do. Not very new, but dual antiplatelets are the mainstay of treating ACS and post-angioplasty patients, which used to be aspirin, which is still there, and followed by clopidogrel. Clopidogrel is now getting replaced with newer and more effective antiplatelets such as ticagrelor and prasugrel, which have in fact been shown to have slightly less bleeding and have better efficacy in terms of preventing recurrent acute coronary syndromes. Currently, there is an intravenous antiplatelet because when a patient comes with ACS, we want to get the antiplatelet level in the plasma to a high level as fast as possible in order to start lysing the platelet thrombi. So most of these drugs are given oral and will take its own time, but cangrelor is an intravenous antiplatelet which is shown to be effective in terms of attaining antiplatelet levels immediately. Moving on to diagnosis of coronary artery disease. Conventional gold standard is a cath lab where we do an invasive angiogram. But currently we have CT scanners, high definition CT scanners, multi-slice CT, which are 128 slice, 256 slice CTs, which are able to give very nice three-dimensional images of the coronary artery like you see here. The patient doesn't need to be admitted. They don't have to be under the cath lab machine. You don't have to take a catheter into the heart. Just like as you would do a CT scan of the chest along with a contrast dye, you are able to get these beautiful images wherein coronary blockages can be diagnosed. These are correlation between CT scan and conventional angiogram showing that very good accuracy of the CT angiograms in diagnosing coronary artery disease. The only flip side to this is in elderly patients, particularly with renal insufficiency and so on, there tend to be a lot of calcium in the coronary, which might decrease the quality of images obtained by CT, and the assessment of degree of stenosis can be a little difficult in the setting of calcium. Talking about calcium, you might be familiar with what is called as a coronary artery calcium score. We all know that atherosclerosis is a inflammatory process wherein deposition of calcium within this atherosclerotic plaque is a very innate process. And so calcium in the coronary artery is almost a surrogate of coronary artery disease. So calcium can be quantified using a low dose CT scan. And these are different images of different patients. What you see in white here along the coronaries is the calcium deposition. This can be quantified into 100 to 400 or more than 400. More the calcium, more chance that you have coronary artery disease. These are not diagnostic because the sensitivity and specificity of calcium scoring is only moderate, but this is a surrogate tool in terms of screening patients, more useful in patients who are young with a low probability in order to diagnose coronary disease. Now, when do we offer angioplasty to our patients? When there is a distinct coronary stenosis, which is more than 70%. So if you look at the angiogram on the left side, very clear, this is a right coronary artery angiogram. You see that at the arrow mark, there is a very critical stenosis, which anybody can tell is around 90% or so and requires an angioplasty. On the right side, the angiogram, you see what can be called as a borderline stenosis. And there is a lot of inter-observer variability in interpreting this. One cardiologist might say this is 60%, somebody else might say 80%, particularly in a climate of litigations where cardiologists are being held responsible for probably excessive stenting and inappropriate stenting and so on. We need objective evidence to say that there is enough stenosis in order to justify a coronary angioplasty, which is where this newer tools of such as fractional flow reserve, what it is basic physics. You kind of take a wire down the coronary artery, which is a smart wire or a pressure wire, which is able to measure the pressure drop across the stenosis. And if the pressure drop is more than 20%, it is deemed to be significant in terms of causing ischemia, and you're justified, or there is an angioplasty is indicated, because long-term trials have showed that FFR less than 0.8, if not treated, might have higher risk of recurrent acute coronary events. So FFR is a foolproof tool in order to give us objective evidence that there is coronary stenosis. Also touch upon a couple of technological advances, which is making angioplasty safe, accurate, with better long-term results. Another one is intravascular ultrasound. These are small, minute ultrasound probes at the tip of the wire, which goes into the coronary artery. Basically obtaining an ultrasound from within the vessel, as you see here, a normal as opposed to a diseased vessel. You can see these bright specks of calcium inside the vessel, as well as a very thick layer of atherosclerotic plaque. Optical coherence tomography uses infrared to get even higher definition coronary images, like you see here, a black and white image on the left and a color image on the right. Very precisely defining the degree of stenosis, the degree of calcium, particularly after angioplasty, to make sure that the stent is appropriately deployed opposing to the wall, and you get a perfect angioplasty result, reducing the risk of recurrent events in the future. So coming back to, again, diabetes and heart disease, I have contrasted two angiograms, a normal angiogram on top and an extremely diffusely diseased calcified angiogram in the bottom. This is what the kind of calcified coronaries that we see in advanced diabetic patients. Again, coming back to calcium, we saw those images on calcium scoring and CTs, where these coronaries are embedded with thick layers of calcium. Previously, these calcified coronaries could not be opened up and patients had to be sent for bypass surgery and so on. Now we have what is essentially a drill which can be taken into the coronary arteries. These are micro drills, as you see here, the width of which is around 1.5 to 2 millimeters. And these shiny things that you see here are actually small diamond studs. And these rotate at a speed of 180,000 revolutions per minute and chisel out these calcium into small particles, which goes down the coronaries, thereby kind of preparing the coronary bed for an effective coronary angioplasty. So we're all familiar with stents. Stents have evolved over several years. Previously, it used to be just angioplasty with a balloon, followed by bare metal stents, followed by drug-eluting stents. And drug-eluting stents have a metal scaffold, and then there is this particular drug, which is basically an anti-inflammatory chemotherapeutic drug, which is eluted from the stent over a period of time. So why do we have these drugs? Because the process of angioplasty itself is actually a traumatic event. Trauma to the vessel causes inflammation. Inflammation leads to restenosis of the vessel, and these drugs prevent restenosis. Newer is what is called as these bioabsorbable stents. So instead of the metal scaffold, there is bioabsorbable scaffold which can be put in place so that we don't leave any material behind in the coronary artery. The initial results were mixed because of the thickness of these scaffold, but newer stents with thinner scaffolds are coming, which can be used in patients wherein a stent, metal stent, doesn't have to be left behind. A short case of a 60-year-old gentleman who has a cardiac arrest on the street is brought to the casualty, found to have pulseless VT and undergoes cardioversion and is resuscitated. Patient has a history of myocardial infarction 15 years ago. So what does this patient have? The patient essentially suffered a sudden cardiac arrest. So sudden cardiac death most commonly happens in the setting of acute myocardial infarction due to ventricular fibrillation. Another reason for sudden cardiac death is ventricular tachycardia, most commonly happening in patients previously who had a myocardial infarction. As you see here, the infarction leaves behind a scar, and the scar is a seat of arrhythmias, because these non-homogeneous scar is where a cardiac impulse can kind of go around in circles, leading to what is called as a ventricular tachycardia. So patients with previous myocardial infarction with very low ejection fraction, less than 35%, with a large scar burden, are at risk of having ventricular tachycardia, which can put them at a risk of sudden cardiac death. If they make it to the casualty on time, we can give them an external defibrillator and save their lives. But now we have what is called as an internal defibrillator. So these patients are handpicked if their EF is low, if their scar burden is high. They are fit with a specialized ICD system. It is essentially a specialized pacemaker which is able to detect ventricular arrhythmias 24/7. If ever a patient has a rhythm predisposing to sudden cardiac death, a shock is given inside the heart, thereby defibrillating the heart and thereby saving a patient's life. That is an ICD to prevent or treat sudden cardiac death and arrest in patients with heart failure with reduced ejection fraction. So moving on to device therapies for heart failure. This is a patient with severe heart failure, similar to the one that we just talked about, with EF is less than 35%. And you would also appreciate that the ECG looks very different. The ECG's QRS is actually very broad and shows what is called as a left bundle branch block. So the wider the QRS, more time it takes for the ventricle to depolarize. And we are all familiar with the bundle branches in the heart, the left and the right bundle branch, which helps the different walls of the heart as well as the different chambers of the heart contract in a synchronous manner. Patients with reduced EF and a left bundle branch block have asynchronous contraction of the ventricle, which can be synchronized electrically, and which is what cardiac resynchronization therapy is. So again, this is another specialized pacemaker where there is two different leads, one on the septum and one on the lateral wall of the ventricle, placed through what is called the coronary sinus, which will help electrically stimulate both the walls of the heart simultaneously to restore synchrony to the heart. And that improves the ejection fraction, improves the left ventricular size, and improves heart failure symptoms. That is what cardiac resynchronization therapy is. It is indicated for patients with heart failure with ejection fraction less than 35%, ECG showing left bundle branch block with a QRS with more than 150, who are symptomatic despite all the 4 or 5 pillars that we talked about, which are heart failure medications. And despite being on optimal medical regimen, if they continue to be symptomatic, synchronizing their heart can help improve heart failure symptoms. We talked about 2 key therapies for heart failure patients. One is for pump failure, cardiac resynchronization therapy, and the second is for arrhythmic death or to prevent sudden cardiac death using an internal cardiac defibrillator. One more quick addition to pacemakers. Traditionally, pacemakers which are implanted for complete heart block and sixth sinus syndrome, we implant 2 leads, one in the atrium, and the second one actually goes to the right ventricle at the apex, as you see here. So we all know that it is not a very physiological way of making the heart contract, because normal contraction happens through the bundle branches, and there is a synchronized contraction from top to bottom. But regular pacemaker is pacing the heart from the apex to the base, which is kind of a little counterproductive. And sometimes that has been shown to have deleterious effect in terms of heart failure and LV dysfunction. This can be overcome with what is a newer technology in pacing, where the lead is actually directly implanted into the conduction system, usually the left bundle area. Thereby, it will make the heart contract in a more physiological manner and thereby have a better long-term outcome for patients requiring pacemakers. So all that we are talking about comes under, so initially we talked about angioplasty and angiograms, which falls under the milieu of interventional cardiology. What we are talking about is electrophysiology, which basically deals with the conduction system of the heart. We talked about pacing, we talked about defibrillation, we talked about cardiac resynchronization. The other rhythm problems we are all familiar with are SVTs, paroxysmal supraventricular tachycardia and ventricular tachycardias. These are rhythm abnormalities, which we can usually diagnose with ECGs. And this most commonly happens in the setting of abnormal pathways inside the heart, abnormal scarred tissue inside the heart, which are better understood with what is called as an electrophysiology study. What it is basically a ECG taken from inside the heart, as you see here. There are catheters placed inside the heart through the femoral vein, and we are able to kind of get a magnified image of how the electrical impulse traverses the heart and detect issues such as pathways and scars. Even more, there is 3D anatomical mapping where we are able to generate three-dimensional images of the heart, which gives us a better spatial orientation to do what is referred to as a radio frequency ablation. Essentially, it is a modality where we are using heat in order to destroy certain conduction elements, which could be an abnormal pathway, it could be an abnormal scar tissue in the ventricle, which predisposes to ventricular tachycardia. So application of radio frequency ablation will either destroy that tissue or make the scar more uniform, thereby preventing the risk of arrhythmias in these patients. Talking about arrhythmia, atrial fibrillation, which is probably the most common arrhythmia that we encounter, which is a dreaded arrhythmia because of the risk of stroke. A fibrillating atrium has stasis of blood in the left ventricular appendage, leading to thrombus formation, which leads to cardioembolic stroke. And we put our patients on vitamin K antagonist warfarin, which is a very potent anticoagulant. But the problem with warfarin is the action is quite unpredictable because depending on the diet and the dosage, the INR values can be very variable. And moreover, INR can shoot up to higher levels, which can put the patient at risk of intracerebral bleeding as well. So we have newer alternatives to warfarin called as newer anticoagulants, such as dabigatran, rivaroxaban, and apixaban. The advantages of which is there is a very steady pharmacokinetic action, so that there is no requirement for an INR check. There is less interaction with diet, and the anticoagulation is very predictable and consistent. But it's important to remember that it's only applicable for non-valvular atrial fibrillation. So patients with rheumatic valvular disease with mitral stenosis have a very higher risk of thrombus formation and stroke, for whom warfarin is still indicated. But patients without valvular problems such as mitral stenosis, but with atrial fibrillation, they can be offered these newer anticoagulants. These used to be quite expensive, but recently they have come off patent, and these are reasonably affordable, and particularly because INR checks do not have to be done. It is also economical in terms of offering these drugs to our patients. So newer anticoagulants, it's very important to be familiar with these names because you will find this on the list. And these, because these are blood thinners, these might have to be stopped 24 to 48 hours before surgery, and sometimes even before dental procedures. Moving on to valvular heart disease, specifically aortic stenosis. We have an aging population. We have a lot of patients going into their 70s and 80s, and more people are having aortic stenosis because they live longer. Particularly India, where bicuspid aortic stenosis is very common. Even in youngsters, we are seeing aortic stenosis. Previously, aortic stenosis had to be treated with open heart surgery by implantation of a new valve. Now there is minimally invasive catheter-based interventions to replace the valve, just like how an angioplasty is done through the groin we put a balloon into the coronary artery and open up the vessel with a stent. Very similarly, we can open up a stenosed aortic valve with a balloon and place a stent over a catheter, and it will remain there, as you see in this picture, making treatment for aortic stenosis very advanced and simple and minimally invasive. It does still require a lot of operator experience. A straightforward case can be done in half an hour as opposed to prolonged hours of surgery and requirement for recovery. For weeks, patients are getting discharged on day 3 and day 2 and day 3 after these procedures. It is still very expensive. It is a few times more expensive than actually doing an open heart valve surgery. But with more types of valves coming into the market and products coming off patent, it could become more and more affordable in the years to come. The other common valvular problem is mitral regurgitation, which is usually a well-tolerated entity until it becomes severe mitral regurgitation. Patients get dilated ventricles with dysfunctional ventricles and go into heart failure. Again, mitral regurgitation is also a mechanical problem which requires a mechanical solution, again in the form of an open heart surgery with valve replacement or repair. Now, this can also be done in a minimally invasive technique using a transcatheter manner. You can see that a common cause of mitral regurgitation is mitral valve prolapse, where the valve is degenerative and it kind of flips over, leading to leakage of the valve. So a mitral clip is what you see here, which will clip 2 of the mitral leaflets together, particularly the one which is prolapsing, thereby prevention of mitral prolapse and as a treatment for mitral regurgitation. Thank you. I think stop there. If there are any questions, I will be happy to take them. Thank you. So just to sum up, we went through a lot of newer drugs which are available for heart patients, newer technology for angiogram, angioplasty, diagnosing coronary disease, treatment for rhythm problems in the form of device therapy, drugs, particularly for hypercholesterolemia. We talked about beyond statin, ezetimibe, and PCSK9, and most recently bempedoic acid. Heart failure, the different pillars of heart failure for heart failure with the reduced ejection fraction. We try to redefine the entity of heart failure with preserved ejection fraction, for which there isn't a lot of pharmacological therapy. But SGLT2 inhibitors have been promising in terms of heart failure, reduction in heart failure with preserved ejection fraction, also in reducing CV mortality in diabetic patients as well. Newer technologies in the form of CT angiogram and coronary artery calcium score for screening and diagnosing coronary disease. Newer technology for angioplasty, including FFR, rotational atherectomy, intravascular ultrasound, and optical coherence tomography. Internal cardioverter defibrillator for sudden cardiac death prevention in patients with scarred ventricle, cardiac resynchronization therapy for heart failure, radiofrequency ablation for arrhythmias, and then minimally invasive catheter-based treatment for aortic stenosis and mitral regurgitation. Thank you. The forum is open for questions. I think the delegates have a different window. They have a comment section. If you have any questions, you can put it in the comment section. We can pick it up and answer. If there are no other questions, we can wind up the session in a few minutes. It's already going to be 9 o'clock. I really appreciate all of you joining us today evening on a nice Saturday evening to listen to the session.
Thank you so much, sir. The talk was very comprehensive, but we haven't yet received any questions yet. Uh, should we wait for some more minutes, sir?
Sure, I think we can wait for another minute.
Okay, sir, sure. If you have any last comment, then you can share it with us.
Sure. There's usually questions about CT angiograms instead of doing conventional angiogram, which we talked about earlier in the presentation. There is a lot of patients who actually come and ask routinely for a CT angiogram to be done as a part of executive checkup and so on and so forth. And I think recently, after the death of one of the celebrities, I think Dr. Devi Shetty came out and made a comment about CT angiogram, saying that angiogram once in 5 years or so. I do not completely agree to those comments which were made, because this is, at the end of the day, it is only a screening tool. And just like you would use any other tests, you look at the pre-test possibility and so on before offering the test to our patients, because these scans will invariably show up some degree of stenosis in the coronary arteries, some degree of calcium, and we should have a definite idea of what to do with these patients. Which is when a functional study becomes very important. The easiest functional study that we can do for diagnosing coronary disease is actually the plain and simple treadmill test. You make a patient walk fast on the treadmill and see for any ECG changes, which gives us a better idea if you are seeing a stenosis on the CT angiogram. Let's say you're seeing a 50% or 60% stenosis. If that is significant, if that is causing ischemia for this patient, can only be answered with a functional study, which is a TMT. So TMT is actually a better functional screening tool for coronary artery disease as opposed to doing a CT angiogram. And it has a better negative predictive value, as in if it is a younger patient in whom there is a less likeliness of coronary disease, it is in those patients that you would offer it. And particularly for elderly patients and for patients with renal insufficiency, it is not a good choice, because these patients tend to have a lot of calcium, and calcium tends to cause a lot of what's called as a blooming artifact on a CT, which helps diagnose coronary disease very difficult. So not a good choice for elderly and renal patients, probably a better choice for youngsters with probably a family history and things of that kind. I have a question from Dr. Ashwin Lal about the TAVR procedure. So TAVR stands for trans-aortic valvular replacement, which we talked about towards the end as a treatment for aortic stenosis. So it is basically a minimally invasive catheter-based technique. In a way, it is comparable to angioplasty. Angioplasty, you have stenosis in the blood vessel, which is opened up with a balloon, and a stent is put in place, which keeps the vessel open. Similarly, in TAVR, we take a balloon across the stenosed aortic valve, open up the valve using the balloon, followed by we put a stent in the position of the valve, which will help keep the valve open. And that is what a TAVR is. It is most commonly done through the femoral artery. A large 14 to 16 French catheter is taken all the way to the aortic arch across the aortic valve, and the procedure is done. Alternative access such as even axillary subclavian access and even direct apical access are alternatives in patients in whom femoral access might be challenging. There was another question about choosing antiplatelets between clopidogrel, ticagrelor, and prasugrel. So by standards, we have moved on to either ticagrelor or prasugrel as a choice of antiplatelet for loading our patients who coming with acute coronary syndrome. So this is the second of the dual antiplatelet. Aspirin still is the first antiplatelet that we use. We give a loading dose of 325, followed by a maintenance of 75 milligrams. Used to be clopidogrel loading of 600, which has been replaced by ticagrelor 180 milligrams. So amongst the different trials which have compared head-to-head between ticagrelor and clopidogrel and prasugrel and clopidogrel, ticagrelor seems to be the most favorable in terms of rapidity of action and lesser bleeding risk, particularly in patients who have to be subsequently sent for coronary artery bypass graft and so on. So ticagrelor is the antiplatelet of choice. Prasugrel is an alternative, but prasugrel is avoided in patients, elderly patients with low body weight and a previous risk of stroke, because this group of patients were seen to have adverse events in the head-to-head trial of prasugrel with clopidogrel. So these are the kind of couple of variables to keep in mind. In elderly patients, particularly if it is not an ST elevation MI, clopidogrel is an alternative because clopidogrel at the end of the day has slightly lower bleeding risk, and that can be offered as an alternative for ticagrelor or prasugrel. Thank you. I think we are at 9 o'clock. If there are no other questions, we can probably.
Sir, no, there are no more questions.
Thank
So,
you. Thank you once again.
Thank you, sir. Thank you for extending us the opportunity to host the session. I hope you had a seamless experience and looking forward to host you again. So, sir, with all your permission, I would like to sign off for today.
Thank you. Thank you and good night.
Thank you so much, sir. Take care.